instead of going through the entire course. If you want to take PALS, if you want to get certified in PALS, you can go online and take an online course, pay the money, and go through the different modules. You take the test, and then I will be glad to administer your skills to you if you want to get PALS certified. But when you're on clinical rotations, really they're only interested in BLS or ACLS, and that's what you're going to have next week. Well, the ACLS. So I'm going to talk about some things today, but on Monday we've added another hour to your afternoon lecture. I'm going to bring an intubation mannequin in here, and we're going to go through, and you're going to practice intubation on this mannequin. It'd be better for you to get the mechanics down here before the December 5th, I think it's 5th, maybe 6th, whatever that Wednesday is, intubation session with the cadavers. Those 3 days are going to be pretty busy with skills. So knowing some of the skills or handling intubation will be helpful. And the reason I bring up intubation is because unlike adults, most emergencies, true emergencies in adults, involve the heart. The MIs, coronary artery disease, stroke, PEs, that sort of thing. It involves the heart. Sudden cardiac death. People, that's why AEDs are everywhere. With the kids, it's respiratory. That's what gets the kids most of the time. There are going to be exceptions, and we'll talk about those today, but it starts out, pediatric emergencies, a lot of times start out as respiratory. And if you just look at the incidence of kids showing up to, there's the objectives. If you look at kids showing up to emergency rooms, you'll see that a fourth of them involve the respiratory system. Now, most of those are going to be asthma related, but you also have to look into things like asphyxiation, drowning, and so on. Okay. You add up the respiratory and the nervous system being mostly seizure related or headache, then that is a lot of ER visits. And of course, accidents and poisonings. And we're going to go into some of these things as we go through today, because they're all tied into pediatric emergencies. If you look at the frequency of visits, it's incredible. And that second bullet point, the frequency is inversely related to wealth. Most of the time you're dealing with the uninsured or the welfare population, which is Medicaid, and the Medicaid system in this state is called Sooner Care. Care with a capital C, one word, Sooner Care. Why? Well, because they don't have primary care providers as a primary reason. Now it says there that 96% are treated and released. That's telling you that 96% of the ER visits in kids are not emergencies. They're not, well, maybe not 96%, but most of those 96% are not emergencies. What are they? Sore throats, ears, fever, that sort of thing. Okay? What you have to do is discern what's a true pediatric emergency and what's not. So, when you look at pediatric emergencies, you consider, when you're developing your differential diagnosis, why is this kid in trouble? It's going to be one of these three things, or it's going to be a combination of those three things. It's either a respiratory issue, a cardiac issue, or a shock issue. And they're related. They're related. And each of these has different levels. Like shock. There are 4 different levels of shock. Respiratory, there are 4 different levels of respiratory. And within those 4 levels, you can have 1 or more problems. So it gets kind of complicated, but if you just get it down to the basics, it's either respiratory or cardiac or shock, then you'll get a long way towards dealing with an acute pediatric emergency. In other words, I'm talking about a kid that's trying to die on you. I'm not talking about the sore throats. I'm talking about you've got minutes to decide what's going on and to act. If you don't, the kid will die. Now, when you go on your rotations, and you're only 3 months from it, understand that if we send you to Blackwell, you're in the hospital with the nurse. Dr. Shewart is at home. If some parent brings their kid in not breathing at 2 o'clock in the morning, it's going to take 30 minutes for Dr. Shewart to get in. You are going to be the front line. So these are the things that you start with. Is it respiratory? Is it shock? Is it cardiac? Is it a combination of those? Then I'm going to tell you how to treat them. Okay? Because if you don't do something before Shewart gets there, I can promise you that kid will die. So, all right. Respiratory emergencies, I said you develop, they're in 4 different levels. They're upper respiratory. By upper respiratory, I'm talking about down to the larynx. Down to the larynx. The trachea is the lower airway. Trachea, the lower airway would be the trachea, the main stem bronchi, lobar bronchi, maybe even tertiary, and then you get out to the lung parenchyma, which is going to be the alveoli. And then finally, it says disordered control of breathing. Something is causing the respiratory rate to be abnormal. That's what that means. Disordered control of the respiratory rate. Regardless of which one or more of the 4 of those that's creating the problem, the kid is going to be either in respiratory distress or respiratory failure. And there's a difference between the 2. Respiratory distress, and it just lists all the different characteristics. Respiratory distress is that kid is struggling to breathe. If any of you have ever seen an asthmatic exacerbation that's out of hand, that is a respiratory distress. The use of accessory muscles, we talked about that in anatomy. They're using the scalene, the intercostals, to try to breathe, okay, try to move air. That's respiratory distress. If the kid is not keeping up their oxygenation, and how would you determine that? If Ronnie, as a 3-year-old, came in, and he's going, and he's mottled, and he's crying, and you can tell this kid's in trouble. How do you know he's in respiratory distress? You know he's in respiratory distress. When does he cross over into failure? Pulse ox or PaO2, you're not going to have that immediately. Pulse ox. If he's not maintaining respiration, his pulse ox is going to fall. You remember the oxygen dissociation curve. It doesn't take much of a decrease in pulse ox to wind up with a really low dip in PaO2, right? Okay. Where it says there, understand that when he starts in trouble, he's going to be tachypnic and tachycardic. Why does it say bradycardia late or bradycardia apnea late? Why is that? Say it again?
His body's like giving up, it's worn down, so he's not breathing.
I'm not catching all of that because I'm 60 and I can't hear worth a crap anymore. But he's tired. He's tired. That's why you get on these kids quick And that's why you support them, because they can't breathe like that. If you tried to breathe like that for 10 minutes, at the end of 10 minutes, you'd be exhausted. This kid's been doing that for 2 hours. You've got to reverse this so that they don't tire out. When they're starting to decrease, that means they are dying. Okay? Anything up here that you don't understand or need explanation for? It's pretty common sense. All right. So let's look at, regardless of which of the 4 levels, upper airway, lower airway, lung parenchyma, disorder control breathing, this is what you want to do. You want, when it says airway positioning in a kid, you think of Charlie Brown. Charlie Brown's got this big round head. That's the same, that's no lie. Kids, their head is way out of this proportion to their body. If Ronnie came in and I was going to bag him, right, I would tilt his head back. And if he had a stable C-spine, I'd tilt his head back, right, to make the airway more straight, right? In a kid, you can't do that. When you do that in a kid, because their larynx is so far up, when you do that, you actually close it off. So that's why you don't do it says head tilt. I'm telling you, that's a caution. You don't, I'm not saying to do a head tilt. I'm cautioning you about a head tilt in a kid because you can obstruct the airway. What you want to do is put them in what's called the sniffing position. You know how you do it like this? You know, like, ooh, you have Mexican food. You know? So my head, my C-spine is not fully extended. It's just like my nose is up and my chin is out, right? Okay? That's what you want to do in a kid. Sniffing position. If you're not getting good oxygenation, if you're trying to bag a kid and it's not working, reposition the head. That's the first thing you do. Reposition the head. Make sure they're not hyperextended. You want to give them oxygen. And remember the thing about oxygen. Nasal cannula gives you no more than 6 liters a minute. The usual airflow in a nasal cannula is 2 to 4 liters a minute. If you have a kid in crisis, then you need to put a mask on. A mask can go 10 to 15 liters a minute, much more. But you want to keep an eye on oxygenation. In a kid, especially in a kid, you want to keep pulse ox between 94 and 99%. You don't let the pulse ox get to be 100%. Why is that? Is what? Oxygen toxicity. That's correct. You can't have more than 100% saturation. The oxygen saturation meter won't go to 101. But remember, oxygen saturation is not, and hemoglobin and dissociation are not the same thing. The normal saturation of hemoglobin is about 80%. The PaO2, the partial pressure of oxygen actually dissolved in blood, is about 80%. Or 80 milli, whatever the unit is, it's about 80. But if you keep pouring on the oxygen, the oxygen saturation will remain at 100%, but you can drive the PaO2, the highest I've ever driven it by mistake was over 500. The PaO2 was over 500. Now a couple of things happen when it gets that high. when it gets high. One is it forms all these oxygen radicals that eat up your brain. The second thing is that if you stop breathing them, your blood is so oxygenated, you won't need to take a breath for 10 minutes. So don't make the mistake of taking the oxygen, oh my God, they're not breathing, put the oxygen back on. That's not what you want to do. To avoid oxygen toxicity, to avoid excessively high PaO2s, keep the sat at 99 to 94. Okay? So pulse oximetry. IVIO. In peds, somebody tries to start a peripheral line, and somebody puts an intraosseous needle in. Whoever gets there first wins. Okay? So intraosseous needle placement in terms of vascular access in PALS is primarily important. Now this is an unconscious kid. You would never put an IO in a kid that's awake. If you try, you will find out why you probably shouldn't do that. In adults, the Heart Association says you get 2 attempts or 90 seconds at a peripheral line. If you can't get it by then, go IO. Now, when we do the cadavers on December 5th, you'll practice you'll put IOs in. It's very simple. Low risk, high rate of success. Okay. But vascular access is important because vascular access, remember the 3 things? One of the 3 is shock. You can't fix shock unless you have vascular access. You get them on a monitor. I'm not talking about an EKG. You don't get a 12-beat EKG. Get them on a monitor. And do basic life support as indicated. If you remember basic life support in peds, if they are unconscious but have a pulse and it's less than 60, you need to be doing chest compressions. If a kid is unconscious, even if they have a pulse, if it's less than 60, you need to supplement, you need to augment that by doing chest compressions. In adults, it's 40. In kids, it's 60. Chest compressions. Any questions about that? Oh yeah, I forgot to. So I also sent you guys, Pam, as I was leaving, Pam Timmons over at Good Shepherd, Starbucks has a deal where they're looking to give money away to charities, community charities. If you do a little short video with your iPhone about what this charity means to you, you can potentially win $25,000 for the charity. If anybody's interested in doing that for Good Shepherd, I'll be glad to talk to you about it. It'd be something nice on a CV if you wound up with it. So just let me know. Okay. Let's look at the 4 airway issues that I mentioned earlier. Upper airway obstruction, there are 3 different types. There's croup. RSV is respiratory syncytial virus. They present the same. And they present as a barking cough. Anaphylaxis is larynx. And aspiration of foreign bodies, most of the time in kids, is in the larynx. This is how you treat them. With croup and RSV, it's steroids. It's humidified air, not vaporized air. It's a cool mist humidifier, not a hot mist vaporizer. They have a thing, if you're going to admit them to the hospital because their respiratory rate is too high or because looks like they're in trouble, there's a thing called a croup tent. You put them in this little plastic bubble in your bed and it is contains humidified air, helps them breathe. And nebulized epinephrine. This stuff is really good, it works really fast, and it turns these kids around really quick. It's called racemic. Racemic means nebulized. Maybe it doesn't, but anyway, that's how when you say racemic epinephrine, it means you're getting epinephrine in the same type of apparatus that you would get albuterol if you were an asthmatic. It's nebulized epinephrine. Remember, it's rescue. It's only going to last a few minutes. That's why it's important to get the steroids on board quickly. And that steroids is IV. Dexamethasone. For anaphylaxis, the acute treatment for anaphylaxis, and don't wait for laryngeal spasms to work. If I've given you a shot of Rocephin and you said, wow, my tongue feels fat, I'm not waiting for you to drop on the floor unconscious with a full-blown anaphylactic reaction. If you start saying my skin is itchy or my tongue feels fat or my lips are going numb, I'm going to hit you with all of that right now. Okay? Albuterol nebulized. Antihistamine, I'm going to give you a beta-2 blocker, which is ranitidine, and a beta-1 blocker, which is Benadryl. I'm going to give you both of them. I'm going to give you IV methylprednisolone, which has a longer half-life than dexamethasone, because that's going to carry you past the anaphylaxis reaction. And if it's serious enough, I'm going to give you IM epinephrine. The dose in kids is 0.01 milligram per kilogram, I believe. It's on that card that I've sent you. That's 1 to 1,000. The adult dose is 0.3 milligrams, I believe. It's 1 to 1,000, 0.3 milligrams.
Why did they change it from sub-Q to IM?
It can be sub-Q or IM, just not IV. Don't give epinephrine IV unless you're running a code.
Is the half-life and time of onset the same?
Yes, it's quick. It's instant. It's instant.
IM, you wouldn't,
Yeah.
usually we've been told that that doesn't take effect as quickly, but, okay.
Just remember what I said about don't give epinephrine IV if they're awake. Don't ever do that.
Can you do dexamethasone for croup IM?
You can. So when you're talking about steroids in an outpatient setting, and you decide, okay, I'm going to give you steroids, whether it's PO or IM, the onset of action is the same. It doesn't make any difference to give them IM steroids because it's around 12 to 24 hours. But IV steroids is quicker, okay? And you're not going to convert them from croup or asthma or anaphylaxis until you get the steroids on board. The steroids, you gotta get the steroids on board quickly. An aspiration of foreign body just goes without saying. Upper airway issues. Upper airway issues, barking cough, I mentioned barking cough. Stridor is another thing. Stridor is, croup when you say barking cough, the answer is croup. Okay, stridor is an increased respiratory effort of the upper airways, like that. It's not asthmatic from down here, it's up in the upper airways. Okay? Hoarseness because it involves the larynx. The commonalities with all four of the different levels of respiratory compromise are tachycardia, pallor, cool skin, cyanosis late, anxiety, agitation, and temperature variability. Okay? You'll see that as we go through here, those bottom 4 things don't change. The top 4 do. If somebody comes in with a barking cough, it's upper airway. If you come in wheezing, it's lower airway. Okay. Lower airway here, the treatment for it is a bronchodilator. Albuterol and ipratropium Atrovent is the treatment for it. Nebulized, not an inhaler, but nebulized. In kids, so the dose of albuterol nebulized is either 2.5 or 5 milligrams. If they're older than 4 or 5 years old, give them the 5 milligrams. There's actually a per kilogram dose. If they're infants up to about 1 or 2 years old, I just stick with the 2.5 milligrams. Atrovent, if they're kids, I always give them a 0.5 milligram. In adults, you can give 1 milligram. So if Ronnie came in, I'd give him 5 milligrams of albuterol, 1 milligram of Atrovent. Knowing full well that that milligram of Atrovent is going to jack his heart rate up to about 140, and he's going to feel pretty jittery. In addition to the Atrovent, it's the beta-2 agonist that's going to make him feel like he's vibrating out of his boxer shorts. So just tone it back when you're dealing with kids. Okay? There's a form of albuterol that you can use in kids that's less, produces less jitteriness. But in the emergency situation, albuterol is the way to go. Steroids, sub-Q epinephrine, if you can't convert them. If you have a person in status asthmaticus and they're closing off, sub-Q epinephrine. Magnesium sulfate also works. It's a competitor of calcium and prevents smooth muscle constriction. Terbutaline is an old-timey beta agonist. If you can't convert them with albuterol and Atrovent, go to terbutaline. And finally, humidified air just helps for the secretions. Remember, asthma, there are 2 problems, constriction and mucus. Keep the mucus moist with humidified air. Okay. Any questions on that?
Is that the cool mist still?
Yeah.
Okay.
Vaporizer is a hot mist. Whenever you say humidifier,
Okay.
that means cool mist.
Okay.
So whereas barking, cough, and stridor were upper airway, wheezing is lower airway. So wheezing is going to be in asthma and in emphysema. The expiratory phase is increased. And that's where you hear the wheezing. It's in the expiratory phase, not necessarily the inspiratory phase. Inspiratory is more upper airway. Expiratory is lower airway. There was a kid that just died in the paper of an asthma exacerbation just recently. DHS custody this week, within the past 5 days. People die of asthma, and you're going to get a lot of asthmatic kids showing up in the emergency room at all hours of the night, and you're not going to have any help. So getting on top of these things is good. Lung parenchyma disease, there are different levels here of lung parenchyma. One of them is infectious, so strep pneumo and so on. The other is chemical. Chemical pneumonitis would be from smoke inhalation or some type of toxin. Aspiration would be during cardiac arrest, there will be vomit in the mouth. And so preventing gastric aspiration or aspiration of gastric contents into the lung is a big deal. You see that a lot in neuromuscular diseases. So that's what you always want to try to prevent, is aspiration. That's why you roll people on the left side or on their side when they have, after you shock them, like with an AED and BLS. Remember the recovery position, you roll on the side. Who do you roll on the left side? Pregnant women, yeah. So that will help. If they aspirate, it'll come out instead of, if they vomit, it'll come out instead of aspirating it. Okay? Pulmonary edema also is an issue related to lung parenchyma disease. You've got cardiac causes of pulmonary edema like congestive heart failure, or sometimes in pediatrics, some congenital heart defects. You have non-cardiac, ARDS is acute respiratory distress syndrome, where the lungs are, it's like a hyper allergic reaction inside the lungs caused by infection or one of a million different reasons, and your lungs start just collapsing down. They're filling up with fluid, they're collapsing. You're not going to have gas exchange, you're going to die. Unless you can reverse ARDS, which is very difficult to do. Consider non-invasive or invasive ventilator support. You guys talked about putting people on a ventilator already. PEEP is positive end expiratory pressure. That's essentially, you're putting pressure to get the air down through a ventilator or through an apparatus. Vasoactive support would be putting them on dopamine, dobutamine, something like that to keep, or epinephrine, or norepinephrine, to keep their pressures up. If you don't keep pressures up, you're going to wind up with CHF, right? And diuretics. Treating pulmonary edema, diuretics would be one way to do it. Another drug to treat pulmonary edema acutely is morphine sulfate. The types of symptoms related to lung parenchyma, I said you got croup, hoarseness, barking cough in the upper, you got wheezing, prolonged expiratory phase in the lower airway. In the parenchyma, you got crackles, you got rales. That's your issue. If there's pulmonary edema, decreased breath sounds. Again, the bottom four are the same. Disordered control of breathing. The reasons for disordered control of breathing can be many. Increased intracranial pressure from whatever reason. Trauma or abuse is rampant in this state. You always need to keep that in mind when you have an unconscious child. Of course, meningitis and encephalitis, tumors and bleeds, or things that you would probably know about beforehand. Poisonings and overdose. There are the five most common poisonings in the pediatric population in Oklahoma are those listed there. Opioids are number one. You got into your mom's OxyContin or whatever. Calcium channel blockers, beta blockers, tricyclic antidepressants, because everybody in this state is on Elavil. If you're not on Elavil for your depression, if you're a migraine headache, you can't sleep, for whatever reason, you need to go be on it. So, because you're the only 36 people that aren't on it. And crack.
Crack cocaine.
Crack cocaine. Not your crack. You got one of those. Okay?
I would have suspected methamphetamine would be really high there.
Not yet. It probably will be. It's crack rocks they get after. Killer rocks. The methamphetamine, the poisonings have to do more with the meth labs, and meth labs are decreasing considerably because most meth in this, now meth is still the #1 killer of adults in the state. But the meth now comes from Mexico primarily, and not homegrown here. When it was homegrown here, it was big because of meth labs. When we were busting over 1,000 meth labs a year in Oklahoma, meth deaths were high. Now, I think this last year, there were only about 200 meth labs in the state, and they were the shake and bake model, not the more not the more organized mass production. Shake and bake is with a 2-liter bottle. You know, you make enough for that day versus making several grams for distribution.
The lady that was found in Walmart doing it on camera, literally.
We're doing a shake and bake?
In Walmart, yeah.
In Walmart, yeah.
She's so out of it.
Oh, yeah. Yeah, as far as adult deaths though, meth is, and probably by the time you're into it, when it says opioids there, no, I don't, probably won't get to the kids, but heroin overdoses are gonna, I mean, that qualifies as an opioid. Right now, the opioids are mostly Oxycontin, hydrocodone, that sort of thing. But by the time you're into this 5 years or so, with the heroin coming down from the north, in the east and west, heroin deaths with fentanyl, they're gonna overtake Oxycontin pretty quick, because it's a lot cheaper.
Is there anything on a drug screen that, like, we would have to, is there any drug that isn't on a drug screen that we would need to do separately to, like, find things like this?
Well, you're not gonna, the calcium channel blockers and the beta blockers,
I meant like like crack, meth, heroin, things like that, are there, yeah.
yeah, so the drug screen right now, I don't know if you guys know what a drug screen looks like, but it's like a pregnancy test. And there are different tests. Some of them test for 8 drugs, some of them test all the way out for 20 different substances. So when it's one test. If you go to Walmart, stop by Walgreens on the way home. You can get it, if you got Ronnie's kids, Ronnie's teenagers here, I don't trust them, he doesn't trust them. He makes his boy pee in a cup once a month. And he tests him at home. And you can do it at home, you can do it to yourself. When you have to start drug testing next year, when you go to, did that weed get out of your system? Go get your kit, if it's positive, you better start coming up with some bullshit excuse why you can't pee all of a sudden. So, yeah. So they'll different types of tests, and there are different levels of testing. There are different sensitivities. The routine test for THC pot weed is the cutoff. The sensitivity is at 50 nanograms per whatever. But when you, in certain circumstances like the military, or if you go to work for different organizations, they use a more sensitive test that will take it down to 25. So you can only, if you smoke, then you'll turn to 50 positive. If you are around second-hand weed smoke, you can turn to 25 positive. So the military uses 25.
Can you reverse channel blockers or beta blockers?
Yeah, so she's asking me, how are we gonna deal with beta blockers and calcium channel blockers? I think I'll get into that later on. So, because it's part of shock. It's part of shock. This is part of shock. If you're overdosed on an opioid, you've got a disordered control of breathing, but you're going to be in shock because of vascular collapse. So that's why I say there are combinations of these things. None of these exist in isolation. You can die, like I said, you can die of asthma. You don't die of asthma because your throat closed off, because your bronchioles closed off. They closed off and you wound up becoming hypoxic, which affect your cardiovascular system, and now you're in cardio, now you're in V-fib. So there are two things to deal with. Okay? Neuromuscular disease, epilepsy, seizures. Seizures are a disordered control of breathing. A person who's had a seizure, during the seizure and in the post-ictal phase, they don't breathe right. So you need to make sure you have airway support during epileptic episodes. Cerebral palsy, any other type of brain injury. Okay? All right, now let's talk about shock. There are 4 different levels of shock. They are hypovolemic, and there are 2 types of hypovolemic shock. You're either bleeding out or not bleeding out. When you get a gunshot to the abdomen and your belly is expanding, that is hemorrhagic hypovolemic shock. If you've got a kid who's been throwing up with that viral illness for 4 days, they're running a fever of 102, they're not drinking. They're peeing only twice a day. They're not taking in fluids. They're hot. They're going to wind up in non-hemorrhagic hypovolemic shock. There's distributive shock, and there are different levels of distributive shock. Anaphylaxis, sepsis, and neurogenic. Neurogenic would be increased intracranial pressure. You hit the head on something. Cardiogenic shock, because of one of these things right here. Like I said, if a kid comes in and the kid has been eating mom's calcium channel blocker, and that kid's heart rate is 20 beats a minute, what are you going to do?
Shock.
Yeah, no. First thing is chest compressions. As I said earlier, if the kid is unresponsive, the heart rate's less than 60, and if somebody's with a pulse of 20, they're going to be unresponsive. You need to be doing chest compressions while you figure out, oh hell, what comes next? Okay? Obstructive shock, okay, CHD, go back up one to cardiogenic shock. CHD is congenital heart disease. It's not a misspelled congestive heart failure. That's congenital heart disease. Myocarditis, cardiomyopathy, hypertrophic cardiomyopathy, and poisons. Obstructive shock, let me do the bottom 3 first. You guys know pulmonary embolism, tension pneumothorax, and cardiac tamponade. Why they can produce PEA, right? PEA, that's what I'm talking about here, PEA. That's an outlet obstruction. If you don't understand why those 3 can produce PEA, you better tell me now, so I can explain it. Okay, the 4th one there, ductal dependent. That happens in the delivery room or very shortly thereafter. By ductal dependent, I'm talking about you have a congenital defect. That defect is what is actually allowing you to oxygenate your blood. Give me an example. If you have a PDA, patent ductus arteriosus, and you have some other types of congenital defects in the heart, and the only thing that keeps that infant alive is that PDA, being able to shunt that blood from one side to the next, you don't want that PDA to close. Now, ordinarily, it's going to close right after delivery or a couple of days later. You want it to stay open, because if it closes, the child will die. Like if you have an overriding aorta, if you have tetralogy or something like that. When we do pediatrics, I'll go into formation of the heart, the embryology of the heart. There are a whole bunch of anomalies that can go on. That you need to have that ventricular septal defect or that PDA to stay open, or the kid will die. The treatment for ductal dependent obstructive shock. Anybody know what the treatment is? What closes, if you have a PDA, and otherwise you're normal, you just have a PDA, and I want to close that after delivery, what do I treat you with?
Ivermectin.
What?
Ivermectin.
Say it again?
Ivermectin.
Ivermectin.
No, it's.
That's for worms.
Sorry. The
Oxytocin?
Huh?
Is it oxytocin? A hormone?
Not oxytocin, not steroids.
NSAID.
What do you treat, what do you close a PDA with?
Yeah, I remember.
Ibuprofen. Did somebody say ibuprofen?
Yeah, she said it says.
Is that what you said, not ivermectin? You said ivermectin would be the pinworms.
Yeah.
Okay, so ibuprofen. Prostaglandins, how does, shit, I just gave you the answer. Why do you treat them with ibuprofen? Because what does ibuprofen inhibit? Prostaglandin synthetase. So you inhibit prostaglandins, you allow the PDA to close. So what do you want to give the kid where you have a ductal-dependent outlet obstruction? You want to give them prostaglandin E2. I think it's E2. Prostaglandin E2. That keeps it open in time to get them to the OR to repair their heart. Any questions about that?
Do rural facilities have that?
What's that?
Do rural facilities have that?
No, absolutely not. Kid's gonna die.
But would you know prior that the
Right.
child had that?
So then you'd have a helicopter.
In Oklahoma, given the number of drop-in deliveries, probably not.
But if you did.
I mean, if you did, they wouldn't be delivering in Blackwell, they'd be delivering over Children's. You're taken straight to the OR. Okay. So, resuscitation of shock. You want to maintain oxygenation, definitely. There's a 94 to 99%. EKG, or not EKG, monitor. Resuscitation, fluid resuscitation. That's what you're going to be dealing with here. In shock, it's fluid resuscitation. Back up here just a second, folks. What defines shock? We know what defines respiratory failure. That's you can't keep up with the O2 centimeter. What defines shock? What's shock?
Poor perfusion of organs.
What? Loss of tissue perfusion. What determines tissue perfusion? What determines how many seconds of capillary refill? Blood pressure. Blood pressure. If you are 1 month old, if you're 3 weeks old, what should your blood pressure be? Your systolic blood pressure should be 60. If you're 1 year old, how much should it be? It should be 70. If you're 4 years old, what should the minimum systolic blood pressure be? It should be 78. If you're 10 years old, what should it be? It's 90. Everybody knows that. You know why I know it? It's on the front page of that card I sent you. Know that. Know that. You should know what the minimum blood pressure, systolic blood pressure should be in a child all the way up to the 10 years of age. At 10 years of age is 90. Adult. From 2 years old to 10 years old, it's 70 plus 2 times the age. So if you're 4 years old, it's 70 plus 8, 78. If your blood pressure is 76, you are in shock. What type of shock are you in? Is it cardiogenic? Is it distributive? Is it so on? Okay? If you're in shock, and that's the definition of shock, your systolic blood pressure. You treat it, the fastest way to treat shock is with fluid resuscitation. Now, I could put you on a pressor like dopamine, but that's going to take a while to mix up. Why don't I just give you a bolus of fluids? As long as your vascular system is intact, you don't have any big holes in it, you should be able to increase the blood pressure. The fluid resuscitation in kids, and don't ever forget this, because 10 years from now, when I see you at the OAPA conference, and I say, JC, what's the fluid resuscitation in a normal kid? You would say 20 mils per kilogram. Administered over 5 to 20 minutes, depending on the circumstance. If it's critical, slam it in there. And recheck the blood pressure. If the blood pressure did not come up, I'd do it again. But I'm only going to do it again after I've listened to your lungs. Why would I want to listen to your lungs? To make sure I'm not drowning you. If I'm pumping all this fluid into you, you need to make sure I don't drown you. So I got Shelby here. She weighs 12 kilograms. She weighs 12 kilograms. She's 6 years old. Her blood pressure is 68. Is she in shock? Oh yes, she's in shock. If she's 6 years old, her minimum systolic pressure should be 70 plus 2 times 6. It should be 82. And her pressure is 68. She's 12 kilograms. Didn't I say 12 kilograms? How much fluid am I going to give her? 12 times 20 is 240. How fast am I going to give it? Fast, because she's got a systolic pressure. I'm going to put it in a 60 cc syringe, and I'm going to sit there and squirt it in her vein. What's the next thing I should do?
Check her blood
Check
pressure.
the blood pressure. Did it work? No, it's still at 68. Listen to her lungs. They're clear. Do it again. And I'm going to do it 3 times. I'm going to give you 3 boluses of normal saline or lactated ringers. Those are the only 2 you get. Those are crystalloids. The other type of IV solution is called a colloid. That would be things that are suspended in like blood or albumin or something like that. Crystalloids are saline and lactated ringers. Not D5, it's just plain normal saline or lactated ringers. I'm going to give you 3 shots. If I'm still not got you back to where I need you, I'm going to have to start giving you blood, because now I've diluted your blood pressure. I've diluted your blood. Andrew here, what blood am I going to give him? I'm going to give him O positive or O negative, don't care. Whatever I can get warmed up the fastest. What am I going to give this 10-year-old? I'm only going to give her O negative.
Does it matter by age or by sex?
The only reason that you're worried about the positive and negative is RH incompatibility. And any reproductive age woman or reproductive potential woman is always O negative. Guys, it doesn't matter. Huh? Because I don't want to sensitize JC, then, 3 years later she gets pregnant at 13 and don't think that little tramp won't. No, but when she's 22 years old, you don't want her to be sensitized. You don't want her blood to be sensitized. So what's the name of the disease? RH incompatibility. What's the name of the disease? I'm 60 years old. I remember this crap. I've told you once. What's the name of the disease? Somebody Google it. Erythroblastosis fetalis. Okay.
I have a question. Wouldn't someone in shock be difficult to start IV access, so you'd probably have an IO? Can you give that as quickly through an IO as you can IV?
You betcha. Probably even quicker. If they have a cardiomyopathy, if there's a heart murmur, back off on the bolus dose to 10. If you know that they have a cardiomyopathy and get in talking to the parents, back off to 10, because it's easier to drown. If it's due to a calcium channel blocker overdose, Samantha, or a beta blocker overdose, you back it down to 5 milliliters per kilogram. Okay? Until you get the heart stabilized. How many times we gonna bolus them?
3.
3 times. What are we gonna do after that?
Blood clotting.
Blood. Okay. So, I'm bringing my 3-year-old into the emergency room. He's unresponsive. He's unresponsive. He's started throwing up last week. He was running fever. He quit. He's not eating very much. He hasn't been eating very much for the past week. And he's unresponsive. And the reason I couldn't get in here earlier is because I ain't in transportation. He's 3 years old. He has blood pressure is 68/40, pulse is 140, respiratory rate is 36, O2 sat 82%. Capillary refill is 7 seconds. On your quick inspection of him, you notice his skin is dry, it's mottled, it's warm. His temp, we'll say his temp is 102. Capillary refill, 7 seconds. He's mottled. His mucous membranes are dry. You notice on him that he has these linear marks, a rash. They're blue, yellow, red, and he is unresponsive. He's unresponsive to pain. What are you going to do with it? First of all, what are you dealing with? You're dealing with, okay, she says, non-hemorrhagic hypovolemic shock. What? Well, you don't know if it's hemorrhagic or not, but probably. I mean, it's got a viral, it's gastroenteritis or something. What else?
Maybe septic shock?
Maybe septic shock. He's got a fever. Septic shock.
Maybe neurogenic,
Neurogenic. Why neurogenic?
because of the bruising, maybe he's been,
Is it bruising or is it the rash of meningococcal disease?
I don't know.
What does a rash of meningococcus look like? If you don't know, you better look at it. You better Google it right now. They're purple macules. What is any bruise that's yellow, red, and black? Why is it yellow? It's old. You don't have old bruises in meningococcus. You're dead. You're right, Taylor. How do you know that this kid is not unresponsive because he's in neurogenic shock? So you're right on all 3. Possible neurogenic shock, possible septic